So welcome to our webinar on money, mental health and prevention. My name is Dania. I'm from the Association of Mental Health Providers. So just to give you a bit of background on this webinar, so we're hosting this webinar with Citizen Advice, and it's the first in a series of 6 webinars that we will be doing as part of a wider project on the Prevention Concordat for Better Mental Health. And this is a project that we've been commissioned to lead by the VCSE Health and Wellbeing Alliance. So the Health and Wellbeing Alliance is a partnership program which is managed by the Department of Health and Social Care, Public Health England and NHS England, and it's made up of 21 organisations and consortiums that represent communities who share protected characteristics or that experience health inequalities. And so through our networks, members of the Alliance, we will link people with lived experience, the communities and VCSE organisations nationally with the aim of connecting policy with practice. This particular project that we've been commissioned to do is looking at the role of the volunteering community sector in preventing and improving outcomes for people with mental health conditions. All of the webinars that we're doing are based on briefing papers, which are due to be published in the summer and aim to create a better understanding of the current prevention landscape at the local level in relation to particular groups of people who experience disadvantage or who face health inequalities. So the webinar and the briefing papers are highlighting the issues that the groups are encountering. So for this particular one, it's looking at people who have financial difficulties, who are living in poverty, who experience debt, and these will outline the role of the VCSE sector in the prevention of mental health. So today the 2 presenters that we have are from Citizen Advice. We will start with Amani Fairak, who is a policy researcher for the National Citizen Advice, and she will discuss the main issue, looking at policy and providing a bit of background information. And then Amani will be followed by Angela Kerr, who is the CEO of Local Citizens Advice Service in South Somerset, and she will be providing information on a service that they are delivering locally. At the end of both presentations, we will have a Q&A session. So if there is anything during the presentation, please make a note of it or just send it through the chat, and we'll keep an eye on that. So over to you, Amani.
Okay, thank you, Dania. Hi, everyone, and thank you for joining us. Can everyone hear me okay? I will take this as a yes.
I can hear you. Hello.
Hi.
Hi.
My name is Amani Fairak, and I'm a policy researcher from Citizen Advice. Just a little bit of background. We are a membership organization and of 300 independent local charities. I'm joined today by my colleague Angela Kerr from Citizen Advice South Somerset. So in today's webinar, we are going to cover what is the link between money and mental health. We are also going to look into the challenges and the barriers facing people and systematic barriers, the impact on services. Then we'll move into the national policy picture and what this looks like. And last but not least, what action we could take or you could take in your locality, how to address deprivation or money problems. After that, my colleague Angela will be sharing her experience, a case study and a service model, how they are working on the ground with clients and providers and commissioners. So what is the link between money and mental health? For the purpose of this webinar, we are going to use deprivation and money problems or financial difficulties as an interchangeable term. So what we mean by deprivation is usually the lack of access to basic necessities. So for example, access to good housing, employment, secure income, like paying back your debt comfortably. Usually the link between mental health and money problem is well documented, and it's a two-way relationship. So for example, if someone has a mental health problem, this leads them to be in a difficult situation financially. Or if someone is having money problems, this will lead them to develop anxiety or depression and other mental health problems. Also, this is very well covered in the literature. People in deprived areas are more likely to have multiple and complex health problems, like they are more likely to suffer from anxiety or depression, be admitted to hospital for mental health treatment, and more likely to, for example, to be obese and die prematurely or approximately 8 years younger than the average adult. More specifically, like around 40–30% of people with mental health problems are in employment compared to 74% of the general population. And only 8% of people with schizophrenia are in work. They are also more likely to live in poor conditions, such as temporary accommodations, being on low income, being at greater risk of being a crime victim. So the impact of these challenges affect people's engagement with mental health services and the overall support. From our research, we know that financial difficulties are the #1 non-health issues that is being raised and discussed at mental health appointment in England, followed by employment and housing. Next, please. So how deprivation or financial difficulties affect people's quality of life? Worrying about money problems can affect the individual productivity at work. There was research that was done by the Money and Mental Health Policy Institute. They did an analysis of the Understanding Society survey. So part of the survey looked into the link between employees' self-reported mental health and financial difficulties. Those who reported at least one mental health symptoms in the past 4 weeks found it difficult to manage financially were over 29% more likely to have poor mental health compared to 12% of those who are financially comfortable. So this analysis basically shows that people who are financially insecure are substantially more likely to report signs of poor mental health. Next, please. So financial difficulties also affect decision making. We did an analysis of YouGov debt tracker. The poll found that people felt significantly restricted by their debt. For instance, a third of people said they were less likely to start a business, and 19% of people said they were less likely to change jobs as a result of their debt or money problems. When we look at people with unmanageable debt, those figures are far higher. And looking at people with a debt-to-income ratio of 3 months' income or more, they're far more likely to say their debt would stop them make key life decisions compared to the general population. Next, please. So people in financial difficulties generally have poorer access to essential services. What I mean by essential services is basically access to mobile connection, energy services. These are basically usually considered like a minimum standard of socially acceptable standard for living, according to the Joseph Rowntree Foundation's definitions. And looking at the relationship between mental health and financial difficulties the other way, people with mental health problems are more likely to struggle financially. They're also more likely to seek advice on multiple and more complex issues than the average client. So for example, 85% of our clients with mental health problems are more likely to seek advice on disconnection from their energy supplies and twice as likely to disconnect from their mobile phone. The next slide, basically, it shows the difference in terms of the client detriment between our average clients and clients with mental health problems. They usually report more complex and more multiple advice needs. Next, please. So how did advice agencies deal with clients presenting with mental health problems? So a bit of background of research. Over 400,000 people struggling with debt consider taking their life in England every year, and more than 100,000 actually attempt suicide. Debt advisors generally see this firsthand, that financial difficulties could drive people to complex mental health problems, including suicidal thoughts and attempts. For example, poor practice of debt collection could put people under pressure, like a bailiff knocking on one's door to demand payment or repossession, are all stress triggers. And such stress triggers could make people think about suicide in order to put an end to their financial worries. So debt advisor come across clients who feel suicidal, struggle with addiction or gambling, for example. And such complex mental health problems requires clinical support or specialist training. And debt advisors are trained in financial advice, but not necessarily in mental health support. And this usually presents a challenge to debt advisors who are not necessarily able to identify someone with mental health or addiction problems unless it is disclosed by clients. More or less, even many debt advisors did not receive training on suicide prevention, gambling, or addiction. And even if a client discloses suicidal thoughts, many debt advisors do not necessarily know if they should breach confidentiality in order to further help their clients. So what is the impact of this on health services? How many problems or financial difficulties can affect health services? We know that, as mentioned, people in deprived areas are more likely to have mental health problems, and this has a knock-on effect on health services. So the number one issue that is discussed during mental health appointments from our research is money or debt problems. And approximately 9 in 1 mental health practitioners have seen debt or money problems raised as an issue by clients during appointments in the past month. So poorer clients are less likely to engage with their treatment or therapy, miss their appointment, and struggle to finish their course of treatment. There was a study by the Money and Mental Health Institute. They did an analysis of IAPT recovery rates in deprived areas, and there was 20% gap in recovery rates between the least and most deprived areas. And this add pressure on mental health practitioners. So some of them, they write letters to governments, employers, and some of them, they actually take time in order to complete benefit forms on behalf of their clients. Some of them, they actually give practical budgeting tips or debt management advice. And only 11% of them feel that they're confident they actually can do that. But they do it because they think it is actually very important to support their clients. There was a report also recently by the NHS providers. They surveyed mental health trusts, and they found out that almost 9 in 10 mental health trusts said that changes to the benefit system, including universal credit, were increasing demand for mental health services, and that they found financial hardship is a key factor in increasing demand. Next, please. So what is stopping people with mental health problems getting support on their finances? Generally, it is the lack of information or limited access is a key issue for people with mental health problems. They often need financial advice, but do not necessarily know where to find information. More than 20,000, for example, people in England were struggling with debt whilst they were in hospital for their mental health. And many thousands more were managing their debt just about whilst in the care of a crisis team in the community. So what type of financial advice do they look for? Usually they seek advice to apply for welfare benefits, how to manage their debt more effectively, or try to help or avoid homelessness due to rent arrears. However, access to that advice is becoming more limited and difficult. So in the CQC report 2018, there was only 29% of NHS clients surveyed in mental health services said that they have received financial or benefits advice when needed, and that was down from 32% the previous year. And almost half of them would have liked to have advice in finding financial advice or benefits, but they did not get it. So what's the result for that? It's usually the clients, their mental health suffers. Next, please. So practical problems like facing financial difficulties and rent arrears, facing homelessness, facing the bailiffs, they're all practical problems could force clients either not to engage with treatment, cancel, or miss their appointments. And in turn, they struggle to complete their mental health treatment. And this could explain why there is a gap in the recovery rate between least and most deprived areas. Next, please. So what's the national picture looks like? General policymakers do recognize the importance of addressing the social determinants of health to reduce health inequality for people with mental health problems. And there are policy drivers to develop mental health prevention program for people who have financial difficulties. So for example, the 5-year forward plan, there was an emphasis on deprivation such as homelessness, which leads to increasing health inequality and poorer mental health. It recommends the Department for Health and Work and Pension to further integrate the employment support in the care pathway for people with mental health by supporting them to find or stay in work, and that is with the aim to have a sustainable or secure income. It also emphasizes that providers should collect data that demonstrate not only clinical outcomes, but also social outcomes, such as employment and housing. And by focusing on identifying people's wider economic needs, this would hopefully that would increase their access to employment and will help channel resources to improve people's health and well-being. Also in the NICE guidelines, it also recognizes the importance of addressing people's wider issues while they're in mental health services. So for example, people who are admitted to hospital and stay for a prolonged period of time, this may present a challenge for them to manage their financial affairs or pay their bills while they're in hospital. So NICE recommends that inpatient mental health providers should assess the patient's wider needs for financial support, housing, and social care before they are discharged from hospital into the community, with the aim that this could help patients to settle in at home and after being away from their home and in the hospital. More recently, the NHS long-term plan highlights the importance of addressing health inequalities by tackling deprivation such as homelessness and unemployment. And it includes a number of national and local initiatives. So some of them, what we already know, the employment support. So the NHS is committed to support up to 20,000 people with severe mental health problems in the next 2 years, and rolling out the employment support for IAPT nationally. The other program is UCLH Pathway Program for Homeless Patients. And that is a program to support homeless patients who have been admitted to hospital, and it involves in-hospital GPs and dedicated pathway nurses working with others to address housing, financial, and social issues for homeless patients. Also, the social prescribing in primary care. So there will be 1,000 social prescribing link workers in primary care, and their role is basically to prescribe personalized support specifically to identify the wider issues facing patients, and that includes their financial or debt issues, poor housing, for example. About also the suicide prevention plan. So the Department of Health has recently published the first cross-government plan on suicide prevention, which aims to work with the NHS, local government, and the voluntary sector with the aim to reduce suicide rate by 10% in the next 2 years. This builds on the Public Health England guidance, which recommends local authority to provide death counselling support or welfare advice as part of local suicide prevention. Next, please. So what actions could be taken? We recognize that this needs collaboration from both sides, from local authorities, companies, accreditors, landlords, employers, voluntary sector, and health services. in order to support people with mental health problems who are in financial difficulties. But there are things that can be done. So one of the things that local commissions and providers could do is to speak to local communities, patient groups, and ask them to share their local data on debt and other advice needs in order to inform local planning and commissioning. So for example, this could be used as evidence in commissioning intentions, the joint need assessment, health and well-being boards, and local suicide prevention planning and other local planning avenues. Also try to identify the debt and other advice needs of people who are both known and those not known to statutory services, such as homeless people, unregistered carers, newly arrived refugees and immigrants, and other vulnerable groups. And you could work with your local community groups and patient groups and the voluntary sector in order to identify these vulnerable groups and see whether their needs are related to money problems, housing, welfare, or other needs. Also, you could try and identify health services that could benefit from integrating debt advice in their settings. For example, think about mental health services or GPs that are practices that are located in deprived wards or localities in your borough, and see which ones that have level of frequent attendance or high demand. There is a possibility that the local population is in need of welfare benefits or access to housing or have other money-related problems, for example. You could also review the provision of debt advice and other support services that address deprivation against the population demand for mental health care and whether it directly meets the need of the local population. Last but not least, please consider to provide training to debt advisors on how to deal with people presenting with common or complex mental health problems and provide guidance how debt advice agencies can link up with mental health services. I hand it now to my colleague Angela, and she will be sharing an example of service model and a case study.
Hi, thanks very much, Amani. My name's Angela. I'm from South Somerset in the southwest, and we're now in our 5th year of working on a discrete service for people with severe and enduring mental ill health. I'm going to take you right back to where we started. And 5 years ago, we recognised that our Somerset Joint Strategic Needs Assessment identified 16% of our local community experiencing mental ill health. When we looked at our data, we recognised that we saw only about 2% of our client group that disclosed mental health. We also saw a number of clients who were obviously struggling with their mental health and who were coming to us in crisis. And so we set out to understand more about how we could help to resolve the problems that were negatively affecting these clients' mental ill health. And the case study that you can see here was our starting point 5 years ago. It's an example where the client is waiting between primary and secondary mental health services. But the first point to make with you is that for this particular individual, their mental health problems led to loss of employment and to an accumulating debt through being unable to continue working and through not being able to sustain their benefits. Next slide, please. The assist advice pathway was developed looking at some of the models of best practice when working in advice and in mental health outcomes. And what we saw immediately was that in the recovery assessment planning of not only our mental health services but others around the country, there was rarely, if ever, a specific recognition or assessment of advice needs within the recovery planning process. We also identified, and this has been verified through our own evidence, that clients had long-standing unresolved advice needs, but they didn't recognise them themselves, or if they did, they were understated when we first met them. This particular client group are least likely to be able to sustain engagement with advice in its more common form. So you might think of a drop-in service. And we could see immediately we needed to do something different to a standard advice model. Moreover, these clients are highly likely to experience changing circumstance. Amani has highlighted some of this through moving in and out of employment, relationship breakdown, poor or insecure housing. And for those reasons, that change of circumstance prompts issues which can lead to complex advice needs. And the very final thing that we recognised at the beginning is that the welfare system is too complex for people who are experiencing mental ill health. So that's where we started. We wanted to design a service that could work alongside mental health recovery to enable the clients to resolve the issues that were affecting their lives, and also to make a full recovery and to sustain their independence as far as possible. We wanted to tackle the root causes of poverty and disadvantage that we recognised in these clients' lives, and to make sure that clients in future would access advice and help earlier, rather than allowing their problems to escalate. You can see that the assist advice pathway here is a prevention-based program, as I've mentioned, and for reasons of funding, we were looking particularly at people who have severe and enduring mental ill health during their recovery phase. The reason we did that was because we see so many of those clients coming to us as they transition from acute treatment into community-based treatment. They have less support at that point, and it's often at that point that we'll see them in an advice service. Long-standing advice issues, as I've mentioned, that may have been in the client's lives for years, that have not been resolved, and the recognition that we needed a service that offered these clients much greater flexibility, extra time, and also a coaching element to build the confidence and skills they need to manage independently as they recover. We often found these clients were very, very vulnerable to poverty premium. Amani mentioned this earlier, but once somebody has been unwell, or their capacity to manage their affairs, their energy, their emotional energy to manage their affairs, can mean that they are paying the most for their electricity and their phone contracts, and that just compounds the poverty and the situation those clients are in. Next slide, please. The model we developed came about through research, consultation with potential clients and existing clients, with partners in the voluntary sector, and with some of the senior officers with the Somerset NHS Partnership Trust, which has the contract to look after the mental health services. So in that sense, it was co-developed. You can see here the goals that we are looking at with our clients: increased confidence, widening support network, achieving recovery goals, and participation. We've had 2 years now working with this outcome framework, and we have refined it as we've gone along. But we particularly wanted to work on one key change for these clients, which was that they will be able to return to advice much more easily and more confidently in the future should they need to use advice services. This mattered because when we spoke to clients, they would tell us that the advice drop-in service was not possible for them to use. It was something that made them feel too anxious, and they told us, we need a named advisor. We need somebody that we can come back to if our circumstances change again and we need help in the future, and we need to be able to have a longer time scale. Often we find with a client, they can sustain an interview with us for half an hour. They might need a long break. They might need to come back next week. We might need to meet them in community. And none of this was possible in the general advice service. So the coaching model starts with an interview with the client where they set their own recovery advice goals. We found that particularly helpful because it engages the client and they take more ownership of their advice. They also then can identify some of the barriers they've experienced in the past that stopped them tackling the problems that they've come for help with. And this might be spending behaviour, motivation, confidence and skill. So through a blend of coaching and advice, we were able to work with the clients over a period of months and a number of sessions to really get to the heart of what was going on for them and to improve the circumstances in their lives. The framework that we used was based on a gap analysis that was produced in Somerset in relation to mental health services, but also we looked at outcome models produced by the New Philanthropy Capital, by some of the other, the Outcome Star and the Warwick and Edinburgh scale. So we had a good look at what was out there. In the end, we built an outcome framework that fitted with the Somerset plans, our local authority public health plans and our mental health service plans, but also spoke more widely to the best practice and established outcome frameworks working in mental health and money in mental health. So the service model works. The next slide, the service model works. As I said, we're recovery focused. We also devote time and energy to building and maintaining trust with clients. This has been essential because it is once we have this trust that there is a full disclosure of the issues that are in the client's life that are affecting their recovery and that are unresolved. The coaching approach alongside the advice involves the client in some of the actions that we are taking with and on their behalf to build their confidence and improve their ability to cope with daily life as they move through our programme. And then, as Amani has mentioned, a lot of the work we are doing is about reducing poverty and improving prospects. I've mentioned earlier that the benefit system is very complex. We see a lot of clients who are struggling with the process for sustaining their personal independence payments if they're moved from disability living allowance to PIP, and these kinds of things cause huge distress. And then, as we saw in earlier slides, the clients we've worked with become much more isolated and will often stop engaging with other support networks. They may not have the money they need to pick up prescriptions or to eat healthily, and so they're stuck in a cycle of poverty and poor mental health. So the model is a holistic model. It's a blend of advice and coaching over a number of sessions related to and linked back to the client's recovery goal. So that leads the whole intervention. On the next slide, we share with you some of the outcomes that we saw for clients last year in our service, where confidence about using advice services at the beginning of our intervention was very low. At the end of the intervention, we saw some great results, and what we hope for is that these clients will come back to advice earlier should they face problems again, rather than coming when they are in crisis. You can see about day-to-day coping skills. At the beginning of our relationship with clients, they were reporting that they were feeling overwhelmed or unable to cope. And through the coaching and the building of the trust with the advice providers that we were working with, they increased in their confidence about being able to manage. And then, most interestingly, what was behind why the clients weren't able to tackle their issues, and making decisions, motivation, confidence and skills were in the mix. So again, what we found through delivering the model we designed was we were fairly accurate in our assessment of the underlying issues for these clients. And so advice plus coaching and support is really important if we're going to move them on and fully resolve their issues. And then finally, for the clients we worked with, we saw a huge improvement in their levels of anxiety as we completed their advice goals, and they moved away from the intense support that they were using with us. Next slide, please. This is a case study again which shows a client moving through secondary mental health services into community mental health. When we met the client, she was on an acute ward, and her support staff there asked us to go along because the client was so worried about circumstances that in her family she couldn't progress with her recovery. The case study here you can see demonstrates this is a young family with children. There was a working partner in the family, and there was a huge amount of debt and a great deal of unresolved issues at home. With the client being unwell, the partner at home also then had to pick up the care of young children. This client was unsuccessful for renewal of personal independence payment, and so that reduced the money coming into the home, and we were able to work with the client and her partner over a long period of time to reinstate her PIP and to support the family through universal credit. We also dealt immediately with the bailiffs, but then over the longer term to achieve a debt resolution for the family. And then that coaching element involved working with this client to engage her in the financial affairs of the family, to reduce the reliance on her husband. And through coaching, she was able to communicate with the suppliers independently and take over the management of bills. We have found in the 3 years that we've been working in the assist pathway that clients who are in a relationship where they don't get involved in managing the family's finances are very much more vulnerable to financial abuse or poverty when something changes in the relationship. That could be through bereavement or relationship breakdown. Particularly we found in women that was an issue, so that's something to flag up. So I think my final slide now is just sharing with you what we have found works. Certainly it supports Amani's point that the advisors on our team needed specialist training. It was way over and above mental health first aid, and the closer we worked with the teams in secondary mental health services, the better we understood their treatment programs, their recovery programs, and they understood more about what we could do. Flexibility of provision is essential. This isn't a 9-to-5 service. We work out of hours, we work out in community. It does take time to build trust with the clients, and it is really only then that all of the issues are disclosed and we can fully resolve the underlying problems. Vulnerable clients are definitely paying poverty premiums, and mental ill health affects our clients' abilities to manage their affairs. We can see that in day-to-day work we're doing with those clients. So whatever model is developed, it does need to take account of time, extended time for the advice intervention, and we would advocate that the client works with their advice service to set their recovery goals and to take full ownership of the service or the advice that they're receiving as they put that advice into action. So that's it from me. Thank you. I'll hand you back now.
Thank you, Amani and Angela. So we will start with questions. I know we had a few.
Just to let you
Carrie.
know, Daniel, I'm unable
Yeah.
to see the chat.
Okay. That's fine. Let's see. Carrie.
It's Patrick
Would
intervening here. One of the people who's watching. I think if Amani clicks on the little red arrow in the top right-hand corner of her screen, she might then see the questions that are being asked.
No, it's the same, I'm afraid.
yeah, for some reason I can't see them either. So if anyone has any questions, would they like to unmute themselves?
Shall I go
just
ahead and answer the questions that were for Amani?
Yes.
Because it's Patrick here. I work at Citizens Advice in Bath. And I was aware a little bit of this research because I've spoken with Amani before about a project that I work on, which is largely benefits advice involving appeals for people with mental health problems. Anyway, my questions that I think are for Amani are, where have I put them down here? There was a mention that half of patients said that they wanted financial or benefit advice but did not receive it. So I was wondering if you could specify where that information has been drawn from. And I've got one other question as well for Amani.
Yeah, in terms of, hello?
Hi.
Yeah, in terms of where this information came from, that was actually in the CQC report published, and they do it, it's an annual survey with patients in mental health services. So that was specific to mental health secondary services. So they survey their patients and they said we do actually want to have financial advice and information, but we do not necessarily have access to it, or we do not necessarily know where the information is.
Is that the same one? I haven't got it in front of me, where 9 out of 10 mental health services said that benefit problems, including universal credit, was causing
that was a
problems?
different report. That was a report by the NHS providers.
Okay. Well, if you possibly you could put it out to us, or a link to that CQC report, so that we know which one it is at some point.
Yeah,
That would be
definitely.
great.
That's fine. We can
Yeah,
share that with you.
if you are happy to share your email, we will be publishing the webinar brief, and it will include all these links. Definitely.
Great. So the second question was, could you mentioned about IAPT, which is the last two digits of which is psychological therapies, so talking therapies, and employment support. And I wondered if you could clarify what the links are between those. I'm aware that there are mental health services which help with benefits to a certain extent, and also that Virgin Care locally does employment support as such. So I just wondered if you could tell us a bit more about, I guess, the national framework for what's expected in that regard, or what exactly the link is between, if there is a link between IAPT and employment support.
At the moment, basically, there are two types of national schemes that I'm aware of. The employment support that is being rolled out in IAP. So this is for people with common mental health problems. So some of this employment support is called EA, that is Employment Advisor. And there is another scheme that is the intensive support placement, and that is aimed at people with severe mental health problems. Does this answer your question?
So what was, sorry, could you clarify a bit more about the intensive support placement?
So the intensive support placement, I believe it's a longer term employment support, where it's basically a structured program for people with severe mental health problems.
And so those sorts of things would be funded presumably through health service budgets, would it?
Yes, by the NHS. That is basically, that is mentioned in the long-term plan.
Okie dokie. Well, again, I think it'd be quite interesting to see some more information about that. I don't want to drag you into a lot of detail now, but it would be useful to.
Hi there. Sorry to interrupt. My name's Lauren, and I actually work in the mental health policy team at NHS England. So it's actually individual placement and support. It's known as IPS. And if you want to drop me an email, I'm happy to provide you with a lot of information about what's going on with that nationally, or I'm happy to circulate something around the whole group if that's helpful.
Yes, that would be interesting. Are the contact details of all the speakers on there? I don't.
Oh,
Yeah,
I'm not one of the speakers. I'm
okay.
just dialed in for interest. But
Oh, okay,
I should be listed as one of the people dialed in, so I can put my contact details up on the chat box actually.
Okay, thanks.
I
okay.
can share those as well after. Is that Lauren Melanie?
Yeah, that's right.
Okay, I can share that with Patrick after. And anyone else
Thank you, Lauren. I should just mention, because this the national policy, I was just giving the overall picture of what is actually being available at the moment. So if you want to have more detail, maybe there is someone in the audience that has more information than me. So thank you, Lauren, for that.
I'm going to put my email address in there. What the hell, might as well. I had what was the last question that I had written up beforehand, which was actually a question for the lady from South Somerset. Sorry, the name slipped from my mind for a second there. Which was how were the, because you could see your outcome percentages, which we obviously have measured in some way. One of those was day-to-day coping skills. May I ask how those outcomes were measured? What kind of questions, I presume it was, that you asked the clients, and how you recorded those?
Hi, thanks, Patrick. We developed a baseline assessment, sort of before and after questions, and we used a set of indicators. A lot of them for those questions, the coping questions, came from the MPC, New Philanthropic Capital Outcomes Map in Mental Health. The reason we used those was because they're already peer reviewed and the indicators are in the public domain, so it wasn't just local to us. So we used a number of questions. We also used journaling, so that each time we worked with the client, we were capturing any narrative from them or update from them across all of the indicators that we were mapping. So it was quite an intense piece of work, and we were able to do that with the funding that we have from the Lloyds Foundation. I would say going forward, it's probably not going to be possible to work to that degree.
In terms of funding, I suppose. Sorry, could you just repeat the name? New Philanthropic
Capital.
They're
outcomes and theory of change specialist. And this is all in the public domain.
Yeah, okay, that's great, thanks.
Great. So we also have a question from Pauline. Pauline, would you like to unmute yourself? I can ask Pauline's question. How long did it take?
Sorry, I can't hear very well.
So Pauline was asking, how long did it take to reinstate PIP? How did she manage financially in the meantime? So I'm guessing that's for you, Angela.
Okay, thank you for that. Unfortunately, it can take a long time to reinstate PIP. With that particular family, there were a number of other things we were able to do. Here in Somerset, we have something called the Local Assistance Scheme, which in other parts of the country may or may not be there. It used to be the crisis loans, and it includes food and fuel vouchers. Are having to go to tribunal, and that in itself is very, very troublesome for those clients, and some of them are opting not to pursue that and going without their money. So for that particular family, we were able to reinstate PIP and mandatory reconsideration, but for some clients we haven't been successful, and we're seeing these clients living with even less income.
We also have a question from Lynn Gibbons. Lynn, would you like to ask a question? I think I'll ask Lynn's question. Lynn was saying that they struggle to get GPs to engage and understand the importance of support for welfare and debt advice. Do you have any examples of good partnership working with GP practices?
Well, if that's from South Somerset's perspective, the irony is that the GP practices that work best with us are in the areas where there is least deprivation. So I don't know if that really usefully answers the question, but I would say in general, there is not a very good understanding among GPs of the help that an advice organisation like Citizens Advice can give, and there's certainly no understanding of how to enable a client to engage. There are a few examples of social prescribing in South Somerset, in Somerset, so not in our area, that are working more effectively with link workers and health coaches, and they're a good interface, I believe, between the GP and the advice services in community, and I think that's improving access. But for the client group that we've been working with, without the extended service, the flexibilities and the specially trained advisors, the general advice service wouldn't meet their need. And we often find they've been referred, for example, for a national debt service that operates by phone, and the clients aren't able to sustain the engagement. So it is, yes, you're absolutely right to ask about GPs and whether they are effective in enabling their patients to use advice. That's one issue that I think we need to improve on. And then the second issue is for some clients, it's not our general advice services that are going to fully meet their needs. It's an additional discrete service that needs additional discrete funding. That's from my perspective in South Somerset.
Thank you. A question from Anna is, how sustainable are the outcomes over time after clients move from service? Is there any longitudinal data?
For us, we don't have a terrific amount of data because we're in now our third year. What has proved to be very helpful that we didn't imagine at the beginning is that Citizens Advice nationally, all of the members are data controllers in common, and so any client that's consented has their record available as they move around the country. So we certainly can start to look more longitudinally. The fact that we have found is that some clients, because they have severe and enduring mental ill health, their circumstances do change and they will have advice needs. I did mention in my presentation, though, that for us a positive outcome is that the client comes to see us earlier before those unmet advice needs have escalated to crisis. And we have some anecdotal evidence, certainly, of that happening. So, for example, a client now in very insecure and poor housing has come to us ahead of receiving their notice to leave for help to deal with the housing department that 2 years ago they would not have approached us in that way, and they would have waited to be presenting street homeless. So there is some evidence. There's potentially a lot more evidence, but that's all I can share.
Duncan is asking if, Angela, you could clarify who funds your service.
Thanks, Duncan. It's called by hook and crook funding at the moment. So we started our work with some funding through Martin Lewis and the National Citizens Advice. We then worked with Lloyds Foundation for their Invest programme, and we hope that we'll be able to secure further involvement from Lloyds. We have a private donation, And in the last 2 years, we have a small amount of funding from Somerset Partnership NHS Trust that we would like to grow. So nothing very secure, but we're always optimistic.
Okay. The next one is more of a statement, I think. So this is from Pamela, who says that it's absolutely commendable that we are having this dialogue. Providing a holistic service is critical to ensuring that all aspects of patients' well-being are accounted for to ensure people are discharged home without fear of what they will be going home to. And of course, we know that finance, money, poverty can be a risk factor in people's well-being. And I think Amani has one more question. So, Amani, I've unmuted you. So if you'd like to go for it.
Oh, thank you. I was not able actually to mute myself. Could you please repeat the question again?
The final one that I just did from Pamela.
Yeah.
So that was just a statement about providing a holistic service is critical to ensuring that all aspects of patients' well-being are accounted for, to ensure people are discharged home without fear of what they will be going home to, and that we know that finance, money, poverty can be a risk factor in people's well-being.
Yes. Can I add as well, we have done a research projects with the Royal College of GPs on GPs' experience with advice services and whether there is a difference between signposting and having an established referral pathway and integrated advice. And they definitely report that they see better benefits in terms of their clinical time spent on resolving these issues and the health outcomes for patients. I'm more than happy to share the report. Also, to answer about whether there's a good practice example in terms of how to work with GPs, one of our services in South Liverpool, they've been working with GP commissioners and they started with a small pilot over a period of time. And now basically the advice in GP practice is rolled across the city. So again, I'm more than happy to share that service model with you.
Brilliant, thank you. So we are coming to the end of our session. If there are any final questions, could we just send them through the questions tab, please? Otherwise, there was an email address that we had up on the presentation that people can use to send any questions, or if they would like any information that they haven't mentioned in this webinar just now. For those who have said that they're interested in receiving reports or other information, we will share your details with the other attendees.
Okay, thank you very much.
Thank you, everyone.
Thank you, everyone.
Thanks. Bye-bye.
Bye-bye.
Thank you.